Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Relatable Rheumatology, From Stories to Studies, a podcast where we explore the personal experiences of people living with rheumatic diseases and the latest research evidence. Each episode invites a patient to share a question or concern that they've encountered during their complex diagnosis and treatment journey to be addressed by our experts. We aim to bridge the gap between patient experience, research, and clinical practice by providing relevant and relatable information. This podcast is a co-production with HCP Live. I'm your host, Dr. Shilpa Venkatachalam, and I'm Director of Research Operations and Ethical Oversight of Patient-Centered Research at the Global Healthy Living Foundation. In today's episode, we will be exploring the topic of chronic pain, what the latest understanding around it reveals, and how it can be managed using a multi-pronged approach. We will also address some misgivings about it and broach some topics that are often difficult to talk about. As someone who lives with chronic pain myself from rheumatoid arthritis, I'm keen myself to learn more about this topic from our guests today. Joining us in this conversation are Dr. Beth Darnall, Professor of Anesthesiology, Perioperative and Pain Medicine at Stanford University's School of Medicine, where she directs the Stanford Pain Relief Innovations Lab. Her work involves developing and investigating novel pain treatments that are scalable, effective, and low burden. She leads multiple pain treatment trials that are active nationally. Very warm welcome to her. I'm also joined by Tien Sydnor-Campbell, who is a medically retired body-centered psychotherapist and former body worker with 25 years of clinical experience. A specialist in the recognition that the body and mind are not separate in healthcare, Tien's role has been to empower clients in managing somato-emotional imbalances. She was diagnosed herself with autoimmune rheumatoid arthritis in 2010 and is a lifelong volunteer and advocate, evidenced through her efforts to educate the public about the unique stigmas and difficulties that Black, Indigenous people of color face in healthcare. So join us in today's episode of Relatable Rheumatology, From Stories to Studies, as we navigate a very big, complicated, and interesting topic as best as we can in under an hour: chronic pain. So why don't we start with you, Tien? Pain is something we all experience from time to time. We get injured, we get a headache, we get a tooth extracted, or a backache every now and then. And in these cases, and often in others, pain is useful. It can be informative. It tells us to take our hand away, for example, from a burning stove, or that we've injured ourselves and we need some rest. However, when pain becomes chronic, it causes major distress and truly disrupts one's life. Can you maybe tell us a little bit about yourself, who you are, what you do, and your diagnosis, and also how you came to realize that pain would unfortunately be part of your everyday life?
So it's really an interesting story, and you know some of it because I started my journey as an athlete. I was a competitive swimmer. I was a person that used to bike to work, 26 miles round trip. I worked at a YMCA so that I could swim and bike and exercise. I was very athletic all the way up through and until my diagnosis. Now, notwithstanding, throughout that whole time, I also had osteoarthritis. So swimming and biking were the ways that I could exercise so that I could, stay in shape, feel good. And I always listened to my body when it's like, okay, no, you need to ice your knees or whatever. I was a specialist in somato-emotional release as a massage therapist because when I was in school, I was the student therapist that would have clients who had emotional releases on the table. And so that became a specialty of mine from the time that I was in school. Fast forward, because chronic pain was always something that I dealt with as a massage therapist, I had all kinds of tips and tricks and ways to deal with chronic issues, ways to help people to get in touch with the things that were still stuck in the soma. Because everything that happens to you has a cellular memory. It's imprinted, right? If you have a way to try and work that out through all the different methods, whether it's massage, chiropractic, acupuncture, meditation, Tai Chi, yoga, stretching, journaling, like whatever you can do to help move the material so that it feels healed and you can continue to do the things that you want to do and get through your life, it's great. When I got the diagnosis, I had just finished a triathlon. A month later, I literally could not stand up straight, couldn't open a bottle of water, could not drive my stick shift vehicle. It was a nightmare. And it was a very different kind of pain. Not only because it was extremely painful, but that it was unrelenting. There was nothing in my toolbox that I could use to get through it without some additional help. Get into medicine, start seeing a rheumatologist, start taking medications. We start, reversing some of the effects because my numbers were sky high from the first diagnosis. I was very lucky in that I didn't have to go years without a diagnosis. But it took a long time and a lot of trial and error and a lot of emotional ups and downs dealing with it, because even as an athlete, there was always a kind of a no pain, no gain. Like, it's going to be painful for a while. You just got to keep going. But when it came to this kind of chronic pain, there were days where I couldn't even lift a 5-pound weight. And it literally brought me to tears because I'm like, if I can't lift this, then what can I lift? And I literally have a 3.5-pound limit on my hands and wrists right now because both of them need reconstruction. So you stop being able to hold things like purses or carrying things when you're holding it and you have to use your wrist. There are adjustments that have to be made physically and mentally and emotionally. And I think the biggest difference when you have chronic pain is the ways that we can address it, even through meditation and hypnosis and medications, that there are still breakthroughs and you still have to deal with it. And the biggest difference is how you deal with it.
As you were speaking, I was just thinking how terrible and how difficult it must have been for you to make these adjustments and even to just accept pain as part of your everyday. I would be remiss if I did not ask you, as a person of color, as a Black woman, was your pain taken seriously? Did it take you substantially long to get your pain addressed? How was that journey?
So there's two things with this. So my osteoarthritis pain, I had been dealing with and complaining with my doctor about for 20 years. And I knew I needed knee replacements before RA got diagnosed, but they wouldn't give it to me because they said, you're too young, right? So you're in pain, but there's nothing we can do because you're too young. I didn't feel like my pain was addressed then, so I just addressed it myself and just dealt with it. But when I got rheumatoid arthritis, it took a very long time, lots of medications that I had to burn through in order to get the kind of treatment that I'm on now, which I think we're going to discuss a little bit later. But it took probably 3 years for the chronic pain itself to be addressed outside of the issue of rheumatoid activity in my joints. So some of the joints were completely deteriorated, and I've been bone on bone for decades.
Thanks, Tien. That was really moving. You touched upon several different things here, and I want to come to Dr. Darnall. Chronic pain is such a big topic here. So I wanted to ask you, from Tien, we understand that chronic pain affects our lives inside out. Obviously, it's not just a physiological experience. There's a very sensory aspect to it as well. We use different kinds of languages around pain. Pain can be throbbing, burning, nagging, sharp, dull, and even experienced as stiffness by many of us living with inflammatory forms of arthritis. And I know that the language that we use can tell us a lot about the types of pain that we're experiencing. Dr. Darnall, can you provide us with a brief overview of what the latest understandings around chronic pain are?
Yeah, sure. I'd be happy to. And thank you, Tien, for sharing your story. It was very powerful and moving. When we think about pain, it's both that noxious sensory and emotional experience. So I think, one of the things that I love about the definition of pain is that it has that personal element to it of how the pain is impacting us, how it's influencing our lives, our emotions, and that's so personal, of course. One of the biggest pieces of that for me is this idea that we've been treating pain pretty compartmentalized and often reductively and neglecting the whole person. And so when we bring in a whole person approach to treating pain, then we have best chances of helping each individual gain relief and also in addressing various aspects of pain that are unique to the individual. So there have been in recent years a very big push towards a whole person assessment, whole person treatments. So we're not just focusing on pain as a biomedical problem. And also on the flip side, that we never want to focus on pain as a psychological problem in isolation. So we want to assess it from this whole person perspective, recognizing that there are these very complex, debilitating medical diagnoses, disease processes at play, assessing all of that and attending to the impacts of the pain and what the individual person can do to address some of those factors so that they're able to live as best as possible with these complex circumstances, with these complex diagnoses, and with ultimately what's often a lot of losses. And of course, there's emotional reactions and responses to that, and they merit our attention and they merit our, really addressing those factors. That's what I think of as the whole person approach. And look, I'm biased. This is my perspective about pain. And if you interview someone else, you're going to get a different perspective. But to me, this is the most exciting development that we're moving more towards this clear understanding that an integrated approach is needed.
Fantastic. Such a big topic, and you did such a good job of just condensing that. There's a lot of misgivings around how we understand chronic pain today, and especially when we're talking about this whole person centered care, which involves both the mental, emotional aspects as well as the bodily, physiological aspects. Dr. Darnall, we often hear about even things like changing thresholds of pain, and there's a lot of misgivings around that. It's as if, there are often times where patients feel like they're being told that they can control how much pain they're feeling, which obviously has to be sort of looked at very carefully. So can you talk a little bit to us about hyperalgesia and central sensitization and how that sort of ties into both the sensory as well as this, I suppose, how it ties into bringing both the mind and the body together?
Yeah, now this is a broad area. And so I'm going to come at this and I just, want to be really honest in declaring I'm not a central sensitization expert by any means, but there is literature both in healthy individuals and in people who have chronic pain. Literature, it's experimental data. So you bring people into a laboratory and usually there's some kind of a pain testing experiment. We call it, evoked pain, where you maybe place a hot thermode on a person's hand, but you cause new pain. And then you're able to study people's reactions to the pain, how much that influences their report of how much pain they're experiencing as a consequence of it. We can put people in the fMRI scanner and see what changes in the brain while people are experiencing pain and how thoughts can influence how much both what is occurring in the central nervous system and how much pain a person is reporting as a consequence of that. So bearing in mind that that is, very different from what anyone may be experiencing in their daily life at home, it's an incomplete correlate, but it does provide us with some evidence about how these mechanisms operate. So what some of the science has told us is that when people are experiencing pain, let's say in the laboratory, that if their mind is attuned to the pain and feeling very helpless about it, so ruminating on it and feeling helpless about it, it amplifies pain processing in the central nervous system. It amplifies people's report of pain. And so I think the reason why this is so delicate is because as a person, if I have pain and I hear that message, I might think, well, they're telling me it's all in my head. I'm making it up. It's all my fault. My pain isn't real. But I can tell you for myself, it does not mean that. What it means is that our mind can be very powerful and it can intersect with various circumstances. And so we think of our brain as it has the capacity to amplify. It can amplify for positive, it can amplify for negative. And even if we step outside of the experience, the topic of pain for a minute, and we can all imagine a scenario, and maybe a scenario that, was stressful, but if we focus on it, we can actually feel ourselves getting upset. It might invoke sadness, it might invoke anger, it might invoke frustration, but we can feel our emotions amplifying as a consequence of where we're placing our attention. So that's literally it. It is an experimental paradigm that illustrates that pain is no different than any other circumstance. If we focused on a stressful conversation with a colleague or a family member, the more we get into it, the more stressful it's going to be. So that's how I think about it. I don't assign overarching meaning to that. I think what it illustrates is there's an opportunity here. This tells us we can work with our central nervous system using various skills and tools to simply be better able to put a container around the distress associated with that medical condition, which can be a very debilitating medical condition. And applying these skills and tools isn't going to erase the medical condition. We're not taking away diagnoses, and we're not even going to take away the pain. What we can do is give people a critical level of control so that if we're able to keep our nervous system calmer in the face of very stressful circumstances, then that's providing us with a level of comfort that can be incredibly meaningful. So as a psychologist, when working with people with chronic pain, my goal always is to identify the opportunities to gain little pieces of control and to expand those. Because there's so much of chronic pain, from the diagnosis to the search for a diagnosis, that can take years. Sometimes people never get it. Sometimes people feel invalidated by the medical system, by insurance. I mean, there's just so many reasons that we feel a loss of control, and it's real. That's real.
Well, thank you. I'm going to take a minute here to absorb that because it's also very empowering. And I'll come to you, Tien. I know you use different management modalities for your own chronic pain. And I'm reminded of the story or the incident. I think this was a UK. It was based in England, where there was a nail driven through a man's shoe. And he was in excruciating pain. And so they rushed him to the hospital. And upon taking him to the hospital and taking out his shoe, they found the nail wasn't even in his foot. Similarly, we hear about the phantom limb phenomenon, etc. So it's really very interesting, and if understood correctly, can be quite empowering to us as people who live with chronic pain. So Tien, coming to you, you were part of a project that we did about 3 years ago that was funded by the Patient-Centered Outcomes Research Institute. on chronic pain titled Encouraging Patients to Manage Chronic Pain Using the Latest Evidence from Research. And one of the objectives of that project was to share evidence-based information on how our understanding of pain is not only changing, but expanding. We have so many tools now to use, right? And I want to say again at the outset, to avoid any misgivings here, that when we talk about pain and emotions, as Dr. Darnall has alluded, we are not saying that pain is all in your head or that pain can be addressed and cured by magical positive thinking. Because those of us who live with chronic pain, myself included, know that this is just not true. I see my joint is swollen and red and I feel the pain. And then there's also the entire topic under neuroplasticity and pain processing that calls for an entirely additional episode. So, Tien, what exactly do we mean by mind-body connection? You are someone who has lived with this experience of chronic pain, and you've also written extensively on how you manage your chronic pain, both mentally and physically. Can you talk a little bit about that?
Yes. And I want to say, in response to what Beth was saying, absolutely, there is something in the mind. Although we will say things like it's not just in your head, it is literally in your body mind. They're not separate. So if psychologically you believe, and this is one of the things that happens when you are early in a diagnosis, I tell you, I know it takes years to get used to it. You begin to catastrophize what else could be going wrong when you start to get new pain patterns, when you start or you would stop being able to do something that you could do literally from morning to afternoon or minute to minute. Walking into a grocery store, thinking you can walk through the grocery store and finding that your limbs are saying absolutely not, because those kinds of things are a reality for people with when we have chronic conditions like rheumatoid arthritis. It is in your body mind. So you do have to learn to process what you think is going on with what's actually going on. My thoughts on the body-mind connection are really there. It's a lot of Eastern philosophy dealing with the chakras and how, with my body-mind somatic psychology background, that those things are also places where we hold emotional issues. So, for instance, if you have chronic pain and you have rheumatoid arthritis, right? I'll use rheumatoid arthritis, and you have chronic pain that just so happens to be in your wrist. So, yes, you can have wrist issues. You can have bone-on-bone issues. You can have crumbling, disintegrating bones like I've got. You can have tendons that are messed up. You can have all those things. Yes, and those will cause pain. But if you are also dealing with what I consider heart issues, love, compassion, fear, pain in your heart issues, holding on to those issues also brings pain. So my approach is to let's talk about the mental, emotional stuff that's in your wrist. And then you also talk to the doctor, physical therapist, occupational therapist about what needs to happen to get your wrist better. Both things are true at the same time. That's my approach.
Well said. I guess what we're saying is you can go so far as to say almost every experience you have, touch, warmth, itch, pain, they're all created and processed by the brain. And so in some sense, it is all in your head, but that doesn't mean it's not real. So, we're bringing the two together. Having said that, Dr. Darnall, I'm going to come back to you. There's a lot of research on using different tools. We talked about, this expansion of understanding chronic pain. And we hear a lot about cognitive behavior therapy or CBT. What is it and how does it help with pain? Can you give us a quick overview?
Sure, happy to. So, cognitive behavioral therapy is the best studied behavioral or psychological treatment approach. I feel like even the word psychological is so stigmatizing to people. So even at but I'm going to use it because that's, the origins of this treatment approach. But it's been studied since the late 80s, believe it or not. So we've got like 40 years of research. So when I say it's the best studied, I mean it's the most commonly studied. I'm not necessarily saying it has the best evidence, because there's other treatment modalities that have been shown to be equally as effective or in some cases superior. But what cognitive behavioral therapy is about, it can be delivered one-on-one or in small group format, usually with, a specialist psychologist or therapist who has training in this modality. If it's delivered in group format, it's usually 8 sessions, each session about 2 hours in length. So, there's a lot of variability here, but it's about 16 hours of treatment. So what happens over the course of this 16 hours? People learn a lot of information. So it's sort of education class-based, like classroom kind of delivery, as well as as people are learning about topics, they're also applying the information to themselves in their own lives. So some of the topics that are covered, it's like, what is pain? So it's basic pain education. It's understanding the intersection between pain and our mood, between pain and sleep, between pain and relationships, pain and activity, setting boundaries, goal setting. It's how pain impacts many different areas of our lives. And with the education, people can then learn how to set, how to identify goals for themselves and how to set goals that are meaningful to them. So I'll give you one example. So often, it's natural that when we feel pain, we stop, we do less. And because pain is a signal that tells us to do that. And so that's a human response, and it's normal and natural. But with ongoing chronic pain, stopping isn't always the best solution. And for some types of pain, in fact, what we need is to help people find appropriate ways of moving, because the movement itself is therapeutic. And so this isn't like a psychological issue. This is overcoming our body's natural tendencies and the way that information of pain registers within us. Pain implores us to stop. Pain tells us to escape whatever is causing the pain. So in this case, it's movement, so we want to stop. But with this learning, and again, this isn't universal. It's not for everybody. For some pain conditions, you do want to stop, okay? But let's just, take it big picture. For some pain conditions, movement is therapeutic. And so we have to overcome that desire, recognizing that the movement, gentle movement is helpful, it is therapeutic, and we might have some ingrained avoidance behavior. We might actually have fear of movement because we're worried about making it worse. And so this is where an integrated approach is really so crucial, because you do need the medical evaluation. You need the medical clearance as part of CBT can be so useful, because you can identify, all right, well, my goal is to walk 3 times a week for 20 minutes. You create a goal that's on your action plan. And so then for that week, you move forward with your goal. When you come back the next week, the group talks about, okay, how did you do with your goals? Were you able to achieve your goal? Did you have any barriers? What were those barriers? And then that's discussed in a supportive therapeutic environment. CBT, group-based CBT, is really lovely because it's the power of the peers. It's each other. You're supporting each other. You're connecting. You feel validated just by the presence of other people. They're sharing their stories. They're talking about their challenges and their successes. And to be motivated and supported by a group is incredibly powerful, because as everyone knows, pain can leave us feeling isolated. We feel alone. Our worlds can become smaller. And so part of the therapeutic process is it's expanding our our goals, but it's expanding the scope of our world. And these group treatments allow for that, just like, connecting on this podcast and as part of this platform is another way to outreach, to learn that you're not alone, to hear success stories, to receive information, to be inspired to apply that in one's own life. So this is really at the core of CBT. It's dedicated. It's a small cohort of people moving together in, a semi-confidential format. I say semi-confidential because if you share information, everyone is on the honor system to not disclose that information. But I'm just saying it's not public. It's a private forum, and it's a safe place for people to create those plans and then move forward with them.
That was great. Thank you. And, me and Tien were both vigorously nodding, perhaps for different reasons. Tien is very experienced with this area of mind-body connection. I was nodding because I recognize, I live with chronic pain, and sometimes I really do resist moving. I have to be honest, because it really hurts to move more. So it's very useful to understand from you what CBT and things like movement, etc., can do for your chronic pain. We're coming to the top of the hour, and I do want to touch on a few more topics. One very contentious one, that of opioids and pain management. And Tien, you alluded to this before. For our listeners, opioids are a class of drugs, medications that derive from or copy natural substances found in the opium poppy plant. All opioids have a similar mechanism of action. They set in motion an area of nerve cells in the brain and body called opioid receptors that stop or essentially block pain signals between the brain and the body. And examples of opioids include morphine, codeine, oxycodone, hydrocodone, and fentanyl. And we all know they work very quickly to resolve pain. I'll be the first to admit that I have used them for excruciating pain on occasions, and they have done wonders for me. We also know that the increase in opioid-related deaths in the United States and in other countries as well has galvanized this national conversation in medicine about the appropriateness of opioids for the treatment of acute and chronic pain. And there's been a ton of concerns about the potential to get dependent on them, on their potential to really recalibrate and lower pain thresholds, something that is often referred to as pain hyperalgesia. And so I know we can't talk about all these issues, but let's just try and touch upon some of them. Tien, as someone who lives with chronic pain, are there times you feel like the pain is too much, that anti-inflammatories and your other medications are just not helping? And when you're in those situations, have you been prescribed opioids, and what was your experience with them?
So I currently take opioids, and I use them as directed. I use them only as directed. And if I feel like I've been given even emergency opioids to use in between, if I'm having non-walking days, I still have to try. And when I try, I mean try. And then I try to soak in the happy of the moment that is outside of getting pain relief, because that pain can be so excruciating that nothing works. And I've been to the ER and I've said, you can't give me anything that I don't already take. So why don't we just go to steroid injection? And I had to go through lots of different medications that did not work. I was taking so much gabapentin and it was doing literally nothing. It wasn't until I took an opioid that I was like, oh my God, relief, right? So let me take the relief. And as long as I need it, I would love to come down off of the opiates. When we find something that actually works to keep me out of that acute pain, I'm all for it. But until such time, don't snatch it away. I think that it's important for people to know their motivations when they're taking the medication, right? And to pay attention to the effects of the medication on their system. And to ask their families to be aware of the medication effects on their system and their family environment. Those are all, everything that goes on in your world is also going on inside of your body. So if you're in a lot of pain and you've been diagnosed, you have diagnoses that allows you or has been, you've been given opiates to deal with the pain, make sure that it is just dealing with the pain. Because sometimes if it's disease activity, then that might mean you need a change in the disease activity, the disease modifying agents, instead of more pain medication. And that's a discussion that I always have with my pain medicine doctors and my rheumatologist. So I hope that answers your question.
Thanks, Tien, for sharing. It does, and it's such a difficult topic, so thank you for sharing with us. I'm trying to, much against my will, bring this conversation to a wrap because I could talk to you both on so many different topics. Dr. Darnall, both me and Tien have talked about how we've turned to oxycodone or opioids for controlling pain at moments when nothing else helps. There's a lot of, patients and doctors have often felt caught in this national crisis around opioids. There are prescribing limitations. Patients feel stigmatized even when they're being prescribed opioids under careful monitoring. Doctors are worried they may be penalized. Can you briefly talk a little bit about whether or not there are benefits around short-term opioid use for pain control? Is there an avenue? I guess what I'm asking is if there is an avenue for the safe use of opioids, especially for those who really need it, and who determines who really needs it in this climate?
Yeah, well, this is a great question. And, I'll just say out of the gate, of course, there's a place for opioids. Of course, there is. And for short term and for long term, opioid use in the right people, in the right circumstances, at the right dose. And, that's for a medical professional to decide. I have testified to the U.S. Congress 3 times advocating for protections for opioid access to patients who need them and for those who are benefiting from them. This is a huge issue. And what we're missing is the therapeutic use, and that there is a subset of patients with complex medical conditions who are gaining benefit. They're helping them be more functional. And what we really need is better research on this topic. It's, one of the problems is that we don't have good funding to conduct research to show who's benefiting from opioids, because wouldn't that be the best study, is to show who's at risk and for whom they don't work, and then to identify those for whom appropriate use is truly therapeutic and helps people be more functional. So we've actually been advocating for more research on this topic. A lot of my work has been focused on helping people need and use as little medication as possible, whether that's NSAIDs, Tylenol, or opioids. There's risks with everything. NSAIDs can be riskier than opioids. There's so many deaths per year on this medication, GI bleeds, you name it. It's underappreciated. What we need is to identify for whom which medication is beneficial, and then to also expand everyone's toolkit. So they're like 10 and they're like, yes, we have this whole toolkit, and this toolkit allows us to need and use as little as possible. I feel like we owe that to every person in America. I just want to say before we close out, we've been studying opioid use in the United States within our group, and we've been studying 1,400 individuals taking long-term prescription opioids, and about 850 of these individuals are across the United States. And we've been asking people, how much benefit do you get from your opioids? And we're going to have some data to share soon. I can give you a little bit of a sneak peek tidbit that unsurprisingly, there's variability. And unsurprisingly, the people who are taking the medications are reporting a crucial level of benefit. And this does not mean that people have addiction. And in fact, we're able to tease that apart and say when opioids are used appropriately, people are reporting X level of benefit. So I'll be happy to share those data with you shortly.
Yes, please do. And please keep us posted on your research. And we'll also provide links to our listeners to some of your research and tend to your writings as well. There is so much to discuss on this topic. We've only really broached the tip of the iceberg here, of course, due to time constraints. Talking about more research, for example, at Creaky Joints, we surveyed about more than 1,000 patients with rheumatic diseases to understand how many of those patients had tried medical cannabis, for example, at least once, most commonly for pain. And whether they had used it or not, we found that 66% said they wanted more information about it, and 54% said they preferred to have that information come from their physician. So going back to your point, Dr. Darnall, I think more research is the key word here. We need more research on a number of topics, whether it's opioids, medical cannabis, etc. And I hope that's where we will go in the future. I want to wrap up this conversation by asking you both about future directions and hopes. There's a ton of research going on. Dr. Darnall, you're doing your own research. You're leading many of your research projects. The National Institutes of Health has diverted millions of dollars to identify better ways to treat pain and less risky treatment options. I've even read about people who are unable to feel pain, right? That can be dangerous too, because pain tells us what to avoid very often. But I think research is trying to gain insights from gene mutations that cause people to lose any sensation of pain, and so on and so forth. All this to say there is much to come in terms of our understanding of where the next decade will lead us to. What are your thoughts and hopes for the future of pain research and treatment? And I'll start with you, Tien, and then hand over to you, Dr. Darnall.
My hopes for the future of dealing with pain management is that every treatment provider is able to see a whole person and treat a whole person and not just their specialty.
Dr. Darnall?
Yeah, well, I love that. And just to build on that, one of the big issues that we have in the country right now is that the providers who are evaluating and treating people with pain don't have access to the full toolkit. They just have access to a tiny toolkit. And so even if they see the whole person, they don't have access to ways to connect patients to the different types of care that they need. So this is what our research is focusing on, is connecting people with a diverse toolkit of non-pharmacologic treatment so that every person in America and around the world, regardless of proximity, regardless of race, ethnicity, regardless of socioeconomic status, and regardless of whether they're connected to a medical institution or health insurance, has open access to this resource. And that's what we're focusing on.
Wonderful. What a hopeful and empowering note to end on. So before we conclude this episode, I would like to pass the mic to my colleague, Dr. Ben Knoll. Ben is Director of Patient-Centered Research at the Global Healthy Living Foundation and has been listening into our fascinating conversation. Ben, a penny for your thoughts. What did you find most interesting in this discussion?
Thanks, Shilpa, and thanks, Tien and Dr. Darnall, for your interesting insights into pain. A few things really struck me about this conversation. One is that pain is not monolithic. When we talk about pain, we're actually referring to a lot of different elements, and it just points to the limitations of our available language. When we talk about pain, we're actually referring to a lot of different things happening at once and a lot of different types of pain, as Tien pointed to when she talked about first realizing she had rheumatoid arthritis and that the pain she felt from the inflammation there was very different from the other pain that she'd felt, either from recovering muscular recovery as an athlete and also as someone living with osteoarthritis. The other thing that struck me too was Tien's articulate explanation of this idea of a body mind, that we're so accustomed to thinking of our bodies, our physical presence, as being distinct or separated from our minds and our thoughts, but actually it's all part of the same thing. So I think that's another area that is interesting to wrap my own head around in my own life, of how our bodies and our minds are really connected. It's not separate or dichotomous.
Thank you, Ben. It's an absolutely ginormous topic, to say the least. Well, thank you very much, Dr. Darnall and Tien, for sharing your experience and your insights with us today on this episode of Relatable Rheumatology.
Thank you so much. It's a pleasure.
Thank you, Shilpa, for always being so helpful in making sure that the advocates have a voice in every conversation surrounding the treatment and care for people with chronic conditions such as rheumatoid arthritis. I really appreciate you. And Ben, thank you.
I hope that our listeners have found this episode insightful. Living with chronic pain poses challenges, both physical and emotional, every day for some of us. And sometimes there's too much information, especially on a topic like this, often contradictory. And sometimes just engaging in a conversation can be difficult because of different opinions and experiences and the plethora of research. And so it can make it really tricky to decode what can be relied upon. That's why we created this podcast, to bring together real-life experiences of people living with rheumatic diseases and expert research evidence to shed light on the questions and challenges faced by those living with these conditions. Remember to subscribe to our podcast so you never miss an episode, and help spread the word by rating our podcast, writing a review, and sharing us with your family and friends. If you have any questions, thoughts, or suggestions for a particular subject you would like us to cover, you can send us an email at podcasts@ghlf.org. We look forward to sharing more information with you during our next episode. This podcast is brought to you by GHLF and HCP Live. Thank you for listening.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.